Good afternoon and welcome to the Health Committee. I'm Delegate Heather Bagnall, Chair of the committee, joined by our amazing committee members. Today is Wednesday, January 28th, 2025, and we will be conducting a series of briefings today, beginning with this one at 1 p.m. with the Department of Health on the Rural Health Transformation Program, HR1, and assisted outpatient treatment. Please be patient if we experience any technical difficulties due to the recent storm. This briefing will be hybrid, with some presenters in person and others online. The committee should have received materials for today. Oh, everyone's in person?
I think so.
Oh, okay. Breaking news. I think we have everyone here in person. You should have received the materials for today in your email. You also have a hard copy at your desks. All of the materials for today's briefings are also available on the MGA website. Additionally, to accommodate the public, we will be conducting today's briefings in 3 sections. So at the end of our first block, we will take down the live feed and return at 2 p.m. With a briefing on certified community behavioral health clinics. And at 3 p.m., we will be joined by the Health and Social Services Subcommittee of the House Appropriations Committee for a briefing from the work group on children in unlicensed settings and pediatric overstays. Please be aware that we have members who are excused but are watching online. We ask that there be no food or drinks in the gallery. You will see our members attempting to stay hydrated because, of course, these are very long meetings. And I ask our members to adhere to the regular rules of our committee, which is 1 question, 1 answer, not 1 question and answer per panelist. And if we do that, we might even have like a little break in between each briefing. With that, we would like to welcome the Maryland Department of Health. Please feel free to introduce yourselves and let's get started.
Great. Good afternoon. My name is Elizabeth Crom, and I'm the Assistant Secretary for Population Health and Strategic Initiatives with the Maryland Department of Health. I'm here to talk to you today about a really exciting program, the Rural Health Transformation Program, and give you a quick high-level overview of our plan and where we're headed for the next 5 years. And I'm unsure if I'm advancing slides or... Okay. All right, so just to recap real quickly where this comes from. This is from the federal level, HR1, and it's $50 billion over the course of 5 years from the federal government. Those dollars are split into 2 buckets. The first $25 billion is what was called baseline funding, and this is basically with a completed and full application. An equal amount will be distributed across the states. And then there's a second bucket that is discretionary, so more dollars can be added to certain states based on a few different factors. We had 6 weeks to put our plan together. This was a rather short turnaround time for such a large engagement. It is a cooperative agreement with the Centers for Medicare and Medicaid Services. That means that CMS will be very involved in the process over the 5 years. And the other key piece of this is that if we do not meet our performance measures, including getting our dollars out the door, we have the risk of having our funding reduced in future project years or dollars that we've already spent clawed back. So it was really important that we put together a plan that was not only innovative and transformative, but also feasible in terms of the ability to implement. So the range of dollars that was available to Maryland through this competitive process was anywhere from $500 million to $1 billion over the course of 5 years. So just a note on what counts as rural and who was using what definition. So when it comes to how we were evaluated for our application by CMS, CMS used federal designated definitions of what constitutes rural. So in this map here, you see the areas that have the hash marks through them in addition to being shaded. Those were the areas that they counted for some of the assessment of our application. For the purposes of the actual initiatives that we propose to be funded through this work, we were able to select our own definition. And so what we went with was what's in our Maryland code, and it's the 18 of 24 counties in Maryland that are defined as rural. So everything that you see on this map here that has a color to it is what we're saying is rural Maryland. So even within the 6-week time frame, we were able to have a pretty robust community engagement process, 17 local listening sessions in person and hybrid options available. Over 200 folks participated from around the state. We did a request for information or request for ideas process through online and email, and we did several roundtable discussions as well. So in terms of our award, we were notified on December 30th of our award, and so we were asked by CMS to submit a budget assuming $200 million a year over the course of 5 years. So that's what we did, and we were awarded $168 million, just a little bit over that. That's 84% of what was proposed was funded. Maryland fared very well, actually, given the size of our rural population, size of our state, some other factors that were a part of the assessment. We received double the average amount per rural resident when you look across the other states. And our revised budget, so we had to, take out 30 or so plus $1 million is due at the end of this week to CMS, and then they have 30 days to approve that revised budget. In terms of our framework, so what we put together, we have, think of them as 3 buckets, 3 initiative areas. And I know that some of the wording is a little bit jargony, but we were also trying to make sure that we were using the language that was a part of how CMS talked about these programs. So when you see sustainable access here, that's really just improving access to healthcare, getting more touch points to bring care to people. So the first initiative is around workforce. The second is around innovative care and improving access. And the third initiative is food for health. Within each of those 3 buckets, we have 2 types of work. The first part is what we're calling immediate impact funds. So these were things that were shovel ready. We had budgets, we had outcome measures, we had things that were ready to go and be implemented from day one, or we had existing programs that we knew could be scaled quite easily. I'll give you an example of this. Within access to care, there is currently right now a grant program to support seeding new primary care practices in Maryland. It's the upstart costs, it's infrastructure, all of that. We know that there were actually applications for new practices in rural counties that were not funded. We are adding to that fund to directly get those practices started in rural areas to improve access to primary care. That's an example of an immediate impact. The second part within each of these 3 areas are transformation funds. So this is where the competition and choice piece comes in. These will be competitive funds. They could be RFAs or they could be RFPs, but we want to encourage the best and brightest ideas from across our rural areas to apply, and we'll see which ones rise to the top, and then we will fund them. The reason why we split this in 2 like this was speaking back to the whole thing of we have the potential to have future dollars taken away from us or clawed back. We needed to have this split so that we could show progress, but also do the appropriate planning work internally to MDH and with our partner agencies to be able to actually then deliver on really good programming in our rural areas. And I see this is hard for me to see from here, so I can't imagine it's easy for you to see. But these are just some examples of the types of work that we're doing in each of the buckets. We've limited time today. I'm more than happy to dive deep into any one of the areas at another time. But on the workforce side, a quick example, we have in Western Maryland right now and on the Eastern Shore an area health education center. These are fantastic centers that help connect training, young folks to training and work between healthcare organizations and community colleges and a lot of workforce exposure and career pipeline work. We think they're great. They have new ideas for programs to expand. We will fund them to expand. We also want to put an AHEC in Southern Maryland. We don't have one. We should have one there. So that's what we'll be doing. And that's an example of an immediate impact fund within workforce. On the food side, none of these funds can be used to purchase food. That was made very clear to us from CMS. But these are one-time funds that can be used to fund critical infrastructure. So through our partners with Department of Agriculture, Rural Maryland Council, through MDEM and the Food Resiliency Council, we were able to identify a series of immediate projects like cold storage, so literally refrigerators, freezers, and other things to help with post-harvest, getting things so that we reduce the spoilage and waste, get to mobile markets, get to food banks, get to others, really try to help with the sort of necessary infrastructure needed to fill in the gaps in our food system. We can move on that now. And then the transformation fund piece for the food side is really where do the aggregators and hubs need to be located in rural areas to best fill out that food system. You see the dollars here. This is where, for our first project year, it splits up. As I think you all would all agree, the biggest bucket is in access to care. It's 126 million, followed by workforce, and then food. And then we do have significant requirements on us in terms of fiscal reporting, audits, and all of that. We had a 10% administrative cap in what we could put in. So we're spending 0.7% right now of our total award on the admin side. And then a note about the funding timeline. So this might be a little too down in the weeds, but I think it's important to think about just all these dollars getting out the door and how we need to get them out the door. We need to have our budgets approved by CMS and everything allocated for this project year, for that 168 million, by September 30th of 2026. So very soon. And right now, we don't have an approved budget, so we can pull down no funds from CMS. We hope to have that, sometime by the end of February. We have, however, once those things are approved, we have until the end of September the following year, 27, to actually spend those dollars. So we have a bit more of a period of time. We just have to make sure that everything is appropriated, allocated, and approved, and then we can spend from there. So the community engagement process was important to us from the beginning, and we're continuing on as we go through implementation. So we're creating a Rural Health Transformation Committee. And we have been, for the past month, seeking volunteers to actually participate in this committee. We really want to make sure that we're representing the perspective of Maryland-based organizations, rural residents, those who actually work and live, work, and play in our rural communities. The initial deadline was on Monday, but due to the snow and some other things, we've extended it to the end of this week. We've already gotten a fair amount of applications in, and that's really encouraging. We want to make sure that we're getting representation from all across rural Maryland and ensuring that we're getting rural serving public and nonprofit entities as well. The first meeting right now is tentatively scheduled for the end of February, and we'll continue making sure that that group meets at least quarterly through the life cycle of the 5 years of this project. We do keep all of the information about this program on our website and update it regularly. We also have a dedicated email. Just thought I'd share this here in case your constituents have questions. They're more than welcome to reach out via email or to contact us directly, but we'll make sure that questions are answered in a timely manner. It's also a really good way for those who express interest of wanting to learn more. We can add them to our list and then blast out updates about grant opportunities and other announcements. And with that, I'm happy to answer any questions.
Thank you so much, and Secretary Crum, it is a pleasure to see you. It's very exciting to hear that we were successful in this grant. I'm going to open it up to our members. Let me start with Delegate Hutchinson.
Thank you, Madam Chair. Thanks for being here. It's great to see there's actually some money out there for the rural communities. Got to get an understanding here, though. So you $168 million for this first year. You're still putting your committee together that would select who would get who would approve those grants. Is that what I'm hearing about this committee? And so you haven't started funding anything just yet. And one more thing in there, I didn't see the word behavioral health anywhere, and would it apply to behavioral health issues?
Yes, okay, so all good questions. So the Rural Health Transformation Committee, think of it as more of a advisory group on the implementation of this large program. We will need to have review committees for any competitive grant process that we go through. We would like to use members of that Rural Transformation Committee to populate those review committees as long as they are not conflicted out, because it could very well be that somebody wants to apply for a grant and then could not sit on the review committee. We have not released any dollars to date because we technically right now have not been approved to draw down our dollars by CMS. We have to submit our revised budget, sort of our reduced budget, because we had initially planned for 200 million. We got to go back in with our 168, 130, whatever million this Friday, and then CMS will have a month to approve that, and that will be the first point at which we can start to draw down funds. So we will be ready come March to begin those shovel-ready immediate impact fundings, and then we're using this period of time to create the request for proposals or request for applications to get the grant funding out.
So if there's an organization today that thinks they have a need for this, could they even apply yet? is that?
They could not apply yet.
Okay, so nobody's behind the 8 ball at this point?
No one's
And-
behind it all. And in terms of behavioral health, we actually, within the access to care, innovative care bucket, there's a dedicated behavioral health transformation fund. So there is dollars specific, and through our partners with the Behavioral Health Administration, there will be grants then awarded specific to behavioral health, and it follows the very nice roadmap of the continuum of services that the Behavioral Health Administration put together. So they're going to be looking to use these grant dollars to fill in those gaps in rural areas.
Excellent. Thank you so much.
Delegate Morgan.
Madam Chair. Great presentation. I want to make sure I understand this and piggyback a little bit on what Delegate Hutchison just said. So this was from the big, beautiful bill that was passed through Congress in July.
Yep.
It had $50 billion set aside for rural area health. My question is, first, you made a comment, and Maryland did pretty well. Glad to hear about that. $168 million has been, I guess, set aside for the state of Maryland and all our rural areas. And I want to give a shout out for Congressman Andy Harris that's been talking about this, and I think he was the only congressman that voted for it. So I appreciate him watching out over rural areas throughout the entire state of Maryland. Would you mind giving me some more comments? I represent Southern Maryland, and rural area health is always a big deal, especially with behavioral health and access to telehealth. Would you mind commenting? I know you touched on it a little bit, but.
In terms of what's available through our
What's the
plan.
goal there to bring to Southern Maryland to increase access?
So,
Because I know you have a plan, we've spoken before.
right. So there are a couple of different areas. One, on the workforce side, certainly bringing that area health education center to Southern Maryland is one piece. Funding in Southern Maryland and in other regions, rural regions of the state, other workforce pipeline development programs. So partnering through our Department of Labor to really grow those out. So there could be existing ones, like there's a really great behavioral health navigator, peer-led model. We would like to do more of that, so we can use funding for that. There's the creation of a public health service corps that we've put in as a part of our application. That would be something that could grow the workforce in Southern Maryland. There's also, when we think about clinical providers, rural Maryland scholars, if there could be that for physicians or advanced practice providers, partnerships with community colleges to grow entry-level workforce pieces and create some more career pathways. And then in terms of access to care, we have a couple of different funds. One is actually around telehealth and connectivity. So identifying those providers who maybe are not connected to our state health information exchange, CRISP, getting them connected, paying for those costs to actually get them connected. Maybe they have other electronic health record needs or other connectivity needs, paying for those types of fees. Figuring out how to have them be able to optimize telehealth would be another piece of that. The other big component in a large transformation fund for us is mobile health. And this could be everything from delivering screenings and tests through a mobile van, all the way to delivering care to a patient in a home through a mobile means. So those are just a couple of examples for Southern Maryland, but really for all rural regions of Maryland, those would be options.
Well, thank you for elaborating on that. As a co-sponsor of the original telehealth bill, I think back in 2015, it's done wonders. We watched it explode during the COVID years, and we'd be kind of lost without it, to tell you the truth, during that time. So we look forward to supporting that. And thank you again for your testimony. Thank you, Madam Chair.
Delegate Ross.
Thank you, Madam Chair. And echoing my colleagues, this was a really great and clear presentation. Thank you. And it is exciting to see this kind of money going toward these rural communities that are a bit more vulnerable. There are many access issues that you highlighted. So my question, though, has to do with the transformation funds. I love the approach that you talked about to get the shovel-ready projects underway and still invest in pursue some of these newer ideas. That is a really smart way to go about it. There's a lot of money on the line, and you want to be using it to do both those things. So can you just elaborate, though, on where the RFPs, I don't know if you've sent them or if you will be sending them, where will they go? Just wondering where those bright ideas for the transformation funds will come from. Thanks.
It's a good question. So we are right now in the process of, we've drafted outlines of a few, and we have a few more to go. We are leveraging our partnerships with our sister agencies wherever possible. So if you think about it on the workforce side, through the Department of Labor, we're working through some of their current programmatic offerings to figure out how we can insert a new RFA, RFP there. Another example would be with Department of Housing and Community Development. They have the Nourish program, which is around seeding individuals to go in hunger hotspots and focus on mobile markets and grocery stores. They don't necessarily have a focus on rural areas, but we can come into that existing grant program and say, fine, we're going to double your dollars, but these are the dollars that are going to go to support the hunger hotspots and putting mobile markets and grocers in rural areas. So wherever possible, we're leveraging an existing state infrastructure and a state partnership agency. Otherwise, we'll go through our means within the Maryland Department of Health, whether it's through the Behavioral Health Administration or Public Health Services, to put out those RFPs and RFAs. We have not finalized the large ones yet, because we're also, to be quite honest, building a budget for $200 million a year, knowing we could get $100 million and half. We didn't want to go too far down the road of building out the transformation funds full scale if we had to cut half of it back.
Thank you. Thank you, Madam Chair.
Thank you very much. And I just want to remind the committee that we have 2 more briefings in this block. I want to give a lot of leeway because this is incredibly exciting and a lot of work that preceded it. But I also want to make sure that we are understanding that for every question, we might be going a little later this afternoon. So Delegate Hill.
Delegate Hill, okay. Thank you. Okay. That's okay. It's okay. You had, then you're there. That was the order I saw. All right, very good.
No worries.
Thank you for the presentation and the work. You talked about the potential for clawbacks. 168, is that, if we're meeting all the metrics, do we automatically get that, or we reapply every year for the amount and show our performance, and they could go up a little higher or down? How exactly does that work?
Yeah. This is going to be fun. We are going to be assessed every year. So we will come back and submit a budget. I mean, there are things that we're proposing that are multi-year efforts, right? So it could very well be that we're given exactly the same amount we were over the course of 5 years. It could actually be, so if other states don't spend or perform and dollars are reduced, we can, for lack of a better term, compete maybe to get a slice of some of those dollars as well. So we could end up with more. We could end up with less. I mean, we have more control over whether we end up with less or not. It's a little more out of our hands in terms of what would happen in order for us to get additional dollars above the 168 each year.
So they keep that control and theoretically can take it back. And then the follow-up is there any opportunity as far as you can see to advance? They can claw back. Can we say we're doing really well this year and we've spent this idea came up, we'd like to implement this. Could you give us an additional within this year? We could use another 20. Is there opportunity to improve within the year and ask for addition when we're doing really well?
So nothing within, I was just thinking through our notice of award. There's nothing that speaks to that there, but that's a really good question that I will take back to our program contact, because I'm not sure. I really don't know, but I'll follow up and I'll let you know.
Appreciate it, thank you.
All right, and the order that I saw is Delegate Gazzoni, followed by Taveras, followed by Kaufman, followed by Cullison. Delegate Gazzoni.
Thank you, Madam Chair. I just have what I hope is a really quick question. You're aware, I think, that the Speaker has set up a rural caucus, and I'm hoping that you are using that to your advantage in terms of additional, contacts and links and partnerships kind of thing.
Yes, definitely.
Cool, excellent.
Excellent question. I had that one written down too. Delegate Taveras.
Okay. So I'm trying to figure out how much of my questions have already been answered or if I could figure them out on my own. But where are we with regards to how are we dealing with, let's say, undocumented population within the rural tier, within this programming structure, and the closing of gaps, let's say food gaps, which I like the idea of cold storage to transport food and such to to the more urban tiers?
So the CMS's Rural Health Transformation Program had several requirements around uses of funds in order for us to participate. And so we were not allowed to apply to use dollars that would supplant, replace, restore other programs that had been cut or eliminated or changed. So what we put together is really thinking more about key barriers to improved health in the rural areas, and then looking to see where we could move the needle, given the limitations of the uses of funds. So that's why we went more on infrastructure building and sort of creating new access points, mobile health, bringing care to people. But I will give you one example on the food front. We have a large line item in there related to nutrition education. We think that nutrition education is very important. We know our local health departments, we know extension, we know a lot of other groups have done what has been SNAP ED in many respects, right? We can't replace SNAP ED, but we can do really good, strong, locally based nutrition education through rural health. So we've tried to, wherever possible, figure out how to address the related health need without running up against what our limitations are for uses of funds.
Thank you very much. Delegate Kaufman.
Yes, thank you, Madam Chair, and thank you for this excellent presentation. I'm a big believer in the social determinants of health. And you mentioned the refrigeration, a little bit about the nutrition, but I'm wondering what your vision is for how you think this funding can help tackle the social determinants of health, and some maybe concrete ideas as to how you're going to use this money to tackle the social determinants of health.
Sure.
Thank you.
That's great. It's a great question. And this is a really nice way to talk about how we're trying to align wherever possible with other things happening. So given the limitations of the funding of this program, and since I could not use these dollars to fund at scale medically tailored meals, for example. We know food is a huge social determinant of health, access to food, right? Access to healthy, nutritious food and diet quality. Over with our AHEAD model, so our total cost of care model, we have a population health improvement fund through that, and we are working to scale medically tailored meals, produce prescriptions, all of that, because we know the importance of it, food as a social determinant of health, but we can pay for food there. We also know that if we want to scale this and get to the point where there is sustainable coverage for these types of these interventions that we know work, they improve health outcomes, they reduce healthcare costs, we don't have the food system in Maryland that can support scaled interventions. So we've used these dollars through the Rural Health Transformation Program to help us figure out where to plug the holes that our friends over in the Department of Agriculture and Rural Maryland Council have told us where they exist, to be able to better figure out the food system, to get more Maryland-grown food into Maryland bellies in a good way, so that we can scale what we know to be those important food-based interventions to address that one social determinant of health.
Madam Chair, I just honestly didn't understand one thing that she said, so can I ask for a definition? Mm-hmm. What's a produce prescription, ma'am?
So a produce prescription it's literally written like a prescription, and it's based on your chronic disease, maybe you have diabetes or you need to have a certain diet. Working with a nutritionist, they put together an outline of the things that should be purchased to create healthy meals, and it's all packaged together and then provided to a patient or to a client.
Thank you very much, Madam Chair.
Madam Vice Chair.
Thank you, Madam Chair, and thank you for your work on this. It's tremendous. Quick question. All this money's coming through CMS, right? So all of the requirements and all of the rules and all of the things that you have to keep up with are CMS determined, correct?
Yes.
Thank you. And the other real quick question, I think, is you mentioned trying to bring more physician practices, provider practices into the rural areas, and that they were, I wasn't sure whether they hadn't had the opportunity to apply, or do they exist and want to be there? I mean, what we hear so much of the time is there are not available providers. And so I was encouraged when I heard you sort of imply that there are providers, but they can't get set up. And if they can't get set up, is it because of financial reasons?
So there is a program called Primary Care Equip, or PC Equip. It's run through our Maryland Primary Care Program. It was a partnership initially with the Health Services Cost Review Commission. And it is literally a grant program to seed the startup of primary care practices. They received a number of applications, actually more applications than they had funding to support. So we do know that they have applications for startup of practices in rural areas that were not funded.
I get it. Thank you very much.
Thank you so much. And I'm not going to ask a lot of questions because my members asked very informative questions. So I will just posit these and then ask that we continue offline, because I would love to know more about that pipeline and also more specifically on if there are any legislative or regulatory changes that we need to open up the pipeline, especially as it relates to apprenticeships. And I just want to say thank you for looking at the financial assistance for those administrative burdens that often are a barrier to our primary care, those small clinics setting up. And with that, I will thank you very much for your presentation and welcome Secretary Briskin, from our Healthcare Financing and Medicaid Director, to talk to us about the updates on HR 1.
Is this microphone? Is this working now? Thank you. Good afternoon, everyone. Thank you, Madam Chair, Madam Vice Chair, for holding this briefing today, and very happy to be with you all and be in a room with many familiar faces. So good to see everyone. So today, let me get my mouse. I'll be giving a little bit overview of the Maryland Medicaid program and then an overview of another part of OBA, the One Big Beautiful Bill Act, and how it's impacting Medicaid coverage for the state of Maryland. So a little bit about Maryland Medicaid. This is the very high level overview. So we are a joint federal and state program. We cover almost 1.5 million individuals in the state of Maryland, just under half of all children, 40% of all births, and we make up 80% of all nursing facility payments. So we are your biggest, and I would like to argue, most important public program. Oh, you can have a mouse. Thank you. Our budget in fiscal year 26 was $15.4 billion. And something I always like to point out about our budget, 96% of that was spent on services and care for individuals. So our administrative costs are just 4%. You compare that with commercial insurance. Commercial insurance, only about 85% is spent on care and services, while closer to 15% is spent on administrative. So Medicaid is a highly, highly efficient program as far as health coverage is concerned. Most of our members receive care through our Health Choice program. Those are our managed care organizations. We have 9 in the state of Maryland and throughout the state. And then lastly, what I will talk about today, we have big changes coming to Medicaid under OBA. So who are Maryland Medicaid members? Again, just to give you an idea, of our members, we have just under 240,000 individuals living with disabilities and 63,000 pregnant women. And most of our members are in managed care plans, as I mentioned, and we do cover a significant number of children and births in the state. We are an economic engine for the healthcare system. We provide payments to over 130,000 enrolled providers throughout the state, including DDA's budget. That is $17 billion going into our healthcare system from the Medicaid program. And so now switching gears, and I think many of you have heard some of this in other briefings, but to review, here are the main eligibility provisions under OBA. First, coming October 1st, are changes to immigrant eligibility. So certain immigrants will no longer be eligible for Medicaid. That includes refugees, asylees, immigrants granted parole for at least 1 year, and certain victims of abuse and trafficking. Note that pregnant women and children will not be impacted, so their coverage will not change. We have adjusted this number over time as we've gotten more data internally, but we're estimating about 15,000 people will no longer be eligible for Medicaid coverage. So as of October 1st, they will fall out and we will not have coverage for them. Then starting January 1st, 2027, so just under a year from today, we will be required to implement work requirements. And so working adults, non-disabled adults, age 19 through 64, will be required to either show that they are working in school or have a medical exemption. Otherwise, they will, as a condition for enrolling in Medicaid, and otherwise they will be disenrolled. We estimate that due to this, not because people are not eligible, but due to the increased red tape and based on historical churn numbers, that could lead up to 115,000 adults losing coverage. This population that these work requirements impact, we call the Affordable Care Act adult population, the ACA adult expansion group. That makes up about 320,000 individuals. So of those 320,000 individuals where work requirements would be applicable, about 115,000 we expect could lose coverage. The other key piece in addition to work requirements is more frequent redetermination. So currently, the majority of people in Medicaid go through a redetermination every 12 months. For this group of ACA adults, it will now be every 6 months. And we know at redetermination, coming out of, especially of unwinding, that is where people tend to fall out of coverage and churn out and churn back in. We also have other provisions such as retroactive coverage opportunities. So we provide retroactive coverage for 3 months prior to enrollment. That will go down to 1 month for the ACA expansion adults. Those are just some of Medicaid's provisions in OBA. There are a series of others which we've listed here. I will not focus on them today, but happy to take any questions. In total, when all the provisions of OBA are implemented, Maryland could stand to lose $2.7 billion in federal funding. The majority of that comes from the coverage loss. So the individuals that are losing coverage receive a higher federal match, and from changes to the Medicaid financing rules around provider taxes and state-directed payments. Diving into work requirements, these are the work requirements the criteria that is in the OBA statute. What's important for Maryland is if you have an income of at least $580 a month, because of Maryland's higher minimum wage, it will be easier for people to reach that $580 a month threshold, which is very good news. And then these are the other pieces that can qualify someone for the work requirements. There's a lot of talk about work requirement exemptions. So there are many exemptions listed in the statute, which is great. I think the part is making sure that people can either attest to that we can confirm it, that we are using existing data in the system, whether it's CRISP, whether it's Department of Labor, whether it's other ways we can get at, do people qualify for an exemption? Medical frailty can be a pretty broad definition, and so we are working to define what that medical frailty is. CMS has released some guidance on what could be defined as medical frailty, but we do think a significant number of our members who are not working and are not in school could qualify for a medical frailty exemption. So this is what we already know about the population. So we know that the vast majority of our members are either working, in school, or would qualify for an exemption. We believe that 85 to 90% of our members are eligible for Medicaid under the work requirements if they can get through all of the different eligibility processes. We only think that 10 to 15% of people are actually not working, not in school, would not qualify for an exemption. And so, of course, we want to, number one, keep eligible individuals covered, but for that 10 to 15%, connect them with work opportunities, volunteer opportunities, job training that would allow them to stay enrolled in Medicaid. This is a visual of when the provisions will go into effect and their impact. We don't expect to see the majority of coverage loss until July of 2027. And that is when the more frequent eligibility checks go into effect. If you think about it for that first round, so people renew throughout the year in Medicaid. There is constantly renewals going around based on when you first entered into the program. People can enter into the program at any time. And so July 2027 is when that first round of initial 6-month redeterminations will happen, and that's when we expect to see the vast majority of people start to lose coverage. So we are doing everything we can to update our systems in a way that makes it possible for eligible people to keep their coverage. It's communications, it's data and systems, it's staffing, and so we want to make it possible for people to keep their coverage if they are eligible. The majority of this population goes through the Maryland Health Benefit Exchange. I know many of you know Michelle Eberly and her team. They are wonderful. They are our partners in this work. So people go to the Maryland Health Benefit Exchange and the Maryland Health Connection to apply for Medicaid coverage. They go there to renew. So a lot of the IT system updates, that will be happening on the MHBE side. This is to give an overview of what our data and systems works looks like at a very high level, and just to show that we are on track. We are also documenting as much as we can for CMS. CMS is requiring extensive reporting of our system updates, but also in the event that we do want to apply for an extension for when we can implement work requirements, we don't know that CMS is going to be granting many of those, but in the event we can, we are doing as much documentation as possible to show our progress. Important here is when things are going into, well, two things are important here. The first is August. So in August, we are going to be sending out the first formal notices to individuals, letting them know these changes are coming. We are going to be starting this spring to do general communications awareness, but the formal notices from the state that we are required to send out will go out in August. Then October 1st, you have the immigration eligibility changes going into effect, and then January 1st, the work requirements, more frequent eligibility checks going into effect. We are leveraging all the data that we have available in the state. We already do a lot with our SNAP partners. We are working closely with our SNAP partners on implementing our requirements, their requirements, making sure we're sharing data. Can we use CRISP data for the medical exemptions? If you are in the CRISP system with a certain diagnosis that would qualify you for a medical exemption, can we tap into CRISP data to see that quickly? Seeing what MSDE data, can we already see if people are in school? We'll probably also be tapping national resources like the National Student Clearinghouse data. So again, trying to make this as automated as possible for our members so we don't have to be asking them to manually submit documentation. A little bit about our communications approach. It's very much an all hands on deck, not dissimilar to unwinding. We had the Medicaid check-in campaign during unwinding, as some of you may remember. We will be bringing that back with an emphasis on these new requirements. I think we are also focused not just getting information out directly to the people who are affected, but to all of our members. People are hearing in the news that Medicaid changes are coming, so we want to protect against a chilling effect and let people know who actually is impacted. The message for our members is keep your contact information up to date on MHBE, so make sure you're aware of the changes. We have information on our website that can already be shared with your members. And we will be working hand in glove with community-based organizations, with our managed care organizations to make sure that people are aware of the changes and what they need to do. We've also posted to our partner, our Hilltop partner, they're a data partner out of University of Maryland. They've created an ACA dashboard, so you can see in each county where these individuals are that are going to be most impacted by these OBA eligibility changes. We're also working to hire and staff for these changes. While technology is wonderful, we do need eligibility workers to still do some of the work, and we are working with our partners to do that as well. These are some of the resources that are already on our website that we plan to continue to add to as the months go on. And with that, that concludes my presentation, and happy to take any questions.
Thank you very much. So we had the good news, and now we've got the less good news. It is 10 of 2, but I want to make sure that we have time to understand what we're hearing, and we know we have another presentation. So with that, I'm going to start with questions. I saw Delegate White-Holland first.
Yes, thank you, Madam Chair, and thank you for your presentation as well. Always a pleasure to see you. When we look at the total losses, and I appreciate you outlining the federal losses in the chart you had earlier, but when we compound that and think about the potential losses of coverage that people will face, if we have an understanding of the impact of what that will have on our larger public health infrastructure, when we're thinking also about uncompensated care, do you have a sense, or could you expound upon what that total impact will be paired with the federal loss of funding that we will have? Is there a number that we have there when we think about, when we look at that, the full burden of what that translates to?
Thank you, Delegate White-Holland, and that's a very good question. So I don't have the total number of uncompensated care that it could lead to. I know the total number in federal funding that it will lead to. I think what we know is that when people do not have health coverage, they end up in the emergency room, and that raises costs for our hospitals. That can impact ED wait times. And so we know there are federally qualified health centers that see anyone that walk through their door. But federally qualified health centers, while they do receive federal funding, they are like any other Medicaid provider. They contract with our MCOs. When they have more uncompensated care, their rates go up, which then increases what we pay them year over year. And so you think of it as, a balloon being squeezed, is that if you take away health care from these individuals, their health needs don't go away, the cost just shifts to higher rates in other parts of the health coverage system. So that's what we're expecting and talking with our larger health ecosystem about. We are also happy and look forward to talking with the General Assembly and you all about options for uncompensated care and for those people that are either churning out of Medicaid or losing coverage altogether due to the new immigration requirements.
Sure.
Thank you. And a lot of lights went on at once, so I'm going to try and do this in the order that I saw it. Delegate Hutchinson.
Thanks for being here. I've seen you do this a number of times, and I know you're working hard to get through this process. The biggest group that seems to be at risk are those the redeterminations that are happening every 6 months. And you just said two things. You're making technology changes, you're adding staff, and you always are using that word red tape. And to me, red tape means it's the government is making that hard for them to do that. You think about like state unemployment. They have to redetermine every week, so they must have the right processes in place to be able to do weekly redeterminations, and we're just only asking every 6 months now. Do you have a level of confidence that says once we weather this storm and you implement those plans in place, that that's not going to be an issue, and you're working hard to make sure everybody who is eligible to be on Medicaid remains on Medicaid.
Thank you, Delegate Hutchinson. And yes, I've been on a bit of a road show, so I feel I'm saying a lot of these again. I think that is our hope, is that we can create an automated system as much as possible, so that when people do need to go up for renewal, we can do mostly through an automated process that does not require them to do anything. Because we know when we require people to physically submit in new paperwork, that's when they fall off. They either don't submit it, they submit it and gets lost, they say it's not worth, it's not worth the trouble, I'm just gonna go without health coverage. We currently in Maryland do auto renewals for about 50% of our individuals. Work requirements is a new process, so we have to see if we're doing 50% of auto renewals on the income side, can we also do 50% of auto renewals on the work requirement side? I think when we look at historic churns in Medicaid, we've never been able nationally to get that churn rate much lower than 20 to 30%. It just can be very challenging. So I think we absolutely want to aim for that. And we want to aim for that for all of our populations, not just this population that's subject to the every 6 months. It would be a dream for all of our populations to be able to go through the health coverage renewal process with a few clicks of a button and nothing more. So that is definitely our North Star. I think we just have a little bit more ways to go. And the hope is that the more we can use technology, AI is incredibly promising. Can that reduce the amount of staff that we need in our departments and our local health departments? So that is the goal. I think it's just going to take a little more time to get there. But we are doing absolutely everything we can to keep eligible people covered, and that will be I think one of our barometers of success. We know what our baseline is. We know an estimate of how many people should stay covered, and then we'll actually see it in practice.
Very much.
Delegate Hill.
Thank you, Madam Chair, and thank you, Madam Secretary, for the work and the presentation. The technology piece, I'm very interested in. I'd love to finish some conversation afterwards. I'm particularly interested because you also recognize that you're going to have human beings to interface to help. And I'm assuming that with these changes, we're also going to see a need for fewer navigators on the healthcare exchange, and wondering if that's some of the workforce that could come over, because my concern is that even with Hilltop doing the tech piece, we have systems now that I know, I was just on a system at the state this week, and when it falls apart and doesn't work, it's really hard to get someone to help me to do what I need to do, and I've got Wi-Fi and all the other stuff. So I'd like to talk to you about how you're going to be beta testing those, some thoughts and ideas, and whether you think, and here's the question, there's so much that you're going to try to do. Is there opportunity, or is it realistic to think you might also, as you're developing these systems, be able to direct people who no longer have care to where they can go other than the ER? Partnering with Lord, say, you need to have this. We know that these are providers in your area that you may be able to reach after 7 p.m. You're looking at any of that kind of stuff, too.
Thank you, Delegate Hill. There's a lot to your question. I will say, first of all, yes, we are looking at where can we point people if they fall out of coverage or are no longer eligible for coverage. And I think that's not just a Medicaid problem, that's a healthcare system-wide issue, and we want to look into that. And do we want to point people to places where they don't just end up in the emergency department? So I think that is something we are actively thinking about. I think to your other question is, yes, we need technology, but we need humans too. And while we hope in the future technology will reduce the need for as much human manual entry, we still have systems that require that. So again, I mentioned the about 50-ish% of individuals that get auto-renewed, you don't need an eligibility worker to verify their application. They go through the system automatically. For that other 50%, you still need individuals to review paperwork and collect paperwork. Now, we're trying to see, can we use AI to expedite any of that and make that quicker? But you still, at least at this point, need both. We can't only have robots. And then, I apologize, what else? Was there another aspect?
You're hiring people, you're looking for people.
Yes.
I
Oh, and
thought not just
navigators.
to navigate.
Yes.
When people are online trying to do these things. Yeah.
Yes. So our partners at MHBE have pretty wonderful customer service. We have our call center. We also use AI chatbots for that, but they also have a network of navigators. We just released the connector entity grants that put navigators throughout the state. And then the people who help to, in our local health departments, do both eligibility verification work and navigation work. We are also working with our community-based organizations to equip them. I think we did this in Unwinding, to say, even if you are not officially a navigator, here are the things you can do in your community to help people with their applications, understand the changes, understand what they have to do. So we are taking an all hands on deck, because we know that for many people, you just need that sort of live, in-person support to get through the system.
Thank you. Thank you, Madam Chair.
Thank you very much. And just a reminder to our members that this is not your last opportunity to talk to the departments. As to Delegate Hutchinson's point, they are on a road show and making themselves available, and we're just getting an update because the guidance is changing. And I will also make a pitch to mobilize our community health workers in this work. Delegate Shalega.
Thank you, Madam Chair. Thanks for being here. I have two questions. One, in the presentation, page 5, you said you estimate 115,000 ACAs could lose coverage because of work requirements. So these are healthy adults without children under, what's the age?
I believe it's 13.
Under 13.
13 and under, yeah.
And who you think aren't going to want to get a job? Or volunteer, because you could volunteer as well.
So that 115,000 actually includes many people who are already working or in school. We think 115,000, based on our historic churn numbers, when people go through redeterminations again and again, that 115,000 could lose coverage, not because they aren't eligible or don't meet the work requirement, but because the process of going through a testing to work requirements or the process of getting redetermined, they could fall out of the coverage program because they can't get through the process.
Put it under work requirements. That's why I was
I apologize for that.
If it was that many people that didn't want to get a job or volunteer. So that's just, you think because of churn.
Yes.
Which churn, just to be clear, that's making people reapply, and through that process, don't you also find out if someone, thank goodness, is making too much money? So they aren't eligible, or they've moved to another state, or maybe unfortunately they passed away. Churn is just not hurdles that people can't overcome, but does it not also help keep the roles honest?
No, thank you for that important question. So yes, we do not want ineligible people in our program. We care about fraud, waste, and abuse. We want people who are living in Maryland, who are under the income limits. We want eligible people in Medicaid. When we talk about churn, we typically talk about people who are eligible, are living in Maryland, are under the income limit, who fall out and come back in within 3 months. And they fall out not because they are not eligible, but because they couldn't get through the eligibility process. They missed an envelope. They didn't sign a form. So we know that the vast majority of that 320,000, I mentioned we estimate about 10 to 15%. We estimate about 30 to 45,000 currently wouldn't meet the work requirement. So those people, if they did nothing, if they did not get a job, if they did not do volunteer, if they did not do a job program, about 30 to 45,000 would fall off. because they would no longer be eligible. But we are estimating, based on historic rates of eligible people who lose coverage through the renewal process, that it could be up to 115,000 who would lose coverage, not because they aren't eligible, but because getting through the system can be so challenging.
And thank you very
And-
much for clarifying that.
Thank you.
I know we wouldn't want to
sorry,
be.
but she said waste, fraud, and abuse.
Delegate?
With auto.
Delegate?
Yes.
I'm going to ask that, I wanted to say thank you for clarifying, because we don't want to give the appearance that we are being disparaging or making assumptions about our vulnerable populations. Now, if you have a follow-up question, go ahead.
Thank you. I would never do that. So please, don't castigate me that way. Thank you. So finally, what are you doing about waste, fraud, and abuse, especially within the auto enrollment program? I'm a little concerned if it's just click a button that there aren't adequate provisions for that. That would be my final question. Thank you.
Thank you for that question. So we have a number of systems already in place to make sure that people are enrolled in our systems. We use federal databases to check income, to check immigration status, to check state residency. When I say auto enrollment, they are not just getting reviewed without the click of a button. It's technology that reviews existing data that we already get from the state and the federal government to check their most recent income. So it's information that an individual would be providing to us manually, but we're able to tap our quarterly wage hub or other data sources to confirm eligibility. So the system is working very, very hard in the background to check income sources. So we make sure that that people are eligible. We are on round-the-clock audits from both the state and federal government on all of our systems. So we are constantly looking out for where there are issues. And when we do audit checks, by and large, we do not have those types of issues in Maryland, I'm proud to say. So happy to share more about that.
Thank you. Delegate Rosenberg.
Thank you, Madam Chair. As you recall, but I don't know how many of my colleagues were even here at the time, under the Clinton era welfare reform, there was a work requirement, and we passed legislation to implement that here in Maryland. What is the process for establishing the work requirements under the House Bill 1, HR 1?
And may I please clarify, how does it differ between like TANF versus SNAP versus Medicaid, or?
Well, my question is, what process must you go through in terms of establishing work requirements for Medicaid? Since we did pass a bill 20-some years ago, I think.
Yeah. Well, on the system side, so the work requirements for each public program differ a little bit, which makes it challenging. I wish that SNAP and Medicaid and their enrollment aligned a little bit better, but that sits at the federal level. So we are currently, again, I think with the work requirement, seeing where there's flexibility, where states have some choice, and where it's pretty prescriptive in what's in the statute. For what does have a little bit flexibility, we see that a little bit on the medical frailty side. We want to make sure we get sort of our interface, in plain language and make it easy so people can get through. We have flexibility on what data sources we use. So can we use data sources that are already accessible to us? Do we need to pay for an outside vendor like Equifax to get more recent data? We are looking at all of these options. We are also making sure that we are aligned as much as we can be with our SNAP colleagues at the Department of Human Services. And so it is not, unfortunately, cookie cutter from other work requirement programs. We're having to create something new, which is why, our estimates on coverage loss and red tape, these are all just estimates. But for a government program to be implemented at this speed this is very fast to be implementing something so comprehensive and brand new.
Okay, thank you.
Delegate Gazzoni.
Thank you, Madam Chair. I had a question, and actually just sort of came up again, around the medical frailty. And so I guess essentially it's, do you have a sense of how prescriptive CMS is going to be, or how much flexibility, whichever way you want to look at it, that the state may have in terms of what those definitions look like? And
We are in the sense CMS is going to be more prescriptive than we originally thought, that there are some federal definitions that we will be held to, but we are still confirming all of that and determining what, ICD-10 codes we can tap for it. But I think initially we thought we would have a lot of leeway, but the federal government, and it makes sense because you don't want 56 wildly different definitions of medical frailty.
Delegate Martinez.
Thank you, Madam Chair, and thank you, Deputy Secretary, for your work that you've done. I think this is like the second or third time I've seen you speak about this bill, and so I know that you're
Don't
working
get
really
tired
hard.
of me. I still want to talk to you all.
No. Maybe the fourth or fifth time. But my question is regarding the non-citizen coverage. I represent a district and a community that cares very deeply about all of its neighbors, and knowing that there are going to be folks in the community that are going to lose coverage because folks in Washington have decided so, right? Where are they supposed to get coverage or care in our communities, in your professional opinion? And then also, how did we get the difference between the 50 to 15,000 to the 60,000 that was originally estimated?
Thank you, Delegate Martinez, and both very good questions. To the first answer, I think that's a question that we all need to work on together, of what we can do for these individuals in the state of Maryland. We know that we can choose as a state whether it's, do we do state-only funded programs? Do we give extra grants to health centers? How do we point people to where they can get care? Prior to the ACA, Maryland had a limited health coverage benefit program for adults that was then supplanted by the ACA. So I think there are a lot of options, and we are very happy to talk with you about those. To your second question, we were waiting for additional data from the Department of Human Services that had more up-to-date recent number of people and their immigration statuses, and that is what led to additional analysis, led to us greatly reducing that number. So these are all estimates. We do the best we can with the data we have, but that was the source of it, is that we got a more updated data file from our partners at DHS and updated the file.
I'm looking to see if I missed any lights. I don't think so. Thank you very much for this presentation. Thank you for keeping us up to date. I know this is, it is complicated and comprehensive, and we know that everyone in this committee wants to just make sure that their constituents are covered and taken care of. And with that, I'm going to say thank you very much. We have one more panel in this briefing, and then we'll be going to our next briefing. So our final presentation for this briefing is on the assisted outpatient treatment. This committee will recall we did a lot of work to create the framework. Our good delegate Johnson was the sponsor, and then the governor took the bill, made it statewide, and I know that you've been doing yeoman's work for the last 3 years, so we look forward to hearing about where we are on assisted outpatient treatment.
Thank you, Madam Chairwoman, and thank you for having us this afternoon. My name is Dr. Rachel Talley, and I'm the Chief Medical Officer with the Behavioral Health Administration. I'm joined by Deputy Secretary Lord from the Behavioral Health Administration, as well as Grace Kelly Anoma, our Program Director for Assisted Outpatient Treatment, and I'm here to provide an update on implementation of AOT in Maryland. So in this presentation, we'll first start with an overview of AOT and the statute in Maryland that passed. We'll next share updates in terms of MDH's implementation approach, including a data analysis that we have performed, as well as information on our internal work plan and some updates in specific buckets of that work plan, stakeholder engagement, as well as development of regulations. So first, to start broadly in terms of an overview, what is AOT, or Assisted Outpatient Treatment? So AOT is a program of court-ordered outpatient care for individuals with serious and persistent mental illness who have a history of non-adherence or difficulty adhering to care. And so this is a community-based program that is focused on improving the health and safety of those individuals, as well as reducing experiences such as hospitalizations and incarcerations for those individuals. And it is intended as another tool in the toolkit for providing mental health services for this vulnerable population. In terms of legislative background, so in the 2024 legislative session, the statute passed in Maryland. The statute requires the establishment of assisted outpatient treatment statewide. It included requirements, rather an option for jurisdictions to elect to implement AOT at the jurisdictional level, and a requirement that jurisdictions notify the department of their intention to implement or to not implement, and included a requirement that for any jurisdiction that declined to implement, the department is required to implement AOT. Lastly, the statute included requirements for the department to develop operational and clinical guidance for the program, as well as report certain outcomes for the program. In terms of some of the content in the statute, specifically in terms of how this program is to be structured. So the AOT process starts with a petition. Any individual 18 years or older with a legitimate interest in the welfare of an individual with serious and persistent mental illness who is felt to meet this criteria may petition the circuit court to request AOT be ordered for that individual. These petitions do have to be accompanied by an affidavit from a psychiatrist who has evaluated the individual within 30 days prior to the filing of the petition and attests to the individual's eligibility and is willing to testify to that eligibility in court. You'll note on this slide that MDH had proposed a pre-petition process for review of these petitions prior to filing. We do have an update in terms of that proposal that's going to come later in this presentation. But going back to statute requirements, once a petition is filed, a care coordination team is then required to develop a treatment plan for the individual. That care coordination team has certain required members, a psychiatrist, a case manager, and a certified peer recovery specialist. And the treatment plan that is developed is required to include the services of a psychiatrist, case management services, and the services of a certified peer recovery specialist. In this process, there are requirements in the statute to offer the individual a reasonable opportunity to engage in development of the treatment plan, as well as if that individual names others who they wish to be involved to engage those individuals as well. And there is additionally an opportunity for the individual through a process called a stipulated voluntary agreement to agree to the treatment plan and then have the proceedings dismissed. In the event that the individual does not agree to that stipulated agreement, the next step, as laid out by statute, is a hearing in the circuit court. And statute includes requirements in terms of testimony, in terms of representation in that hearing. And the circuit court, if they do find make a determination that there is clear and convincing evidence that the individual meets eligibility for AOT, they can issue a court order requiring that individual to be in the AOT program for a period that is not to exceed 1 year. And the statute then additionally includes components around material changes to the treatment plan during the course of the order, requirements for written notifications to the court in the event of a emergency evaluation, as well as a requirement that the care coordination team, if it's indicated, develop a plan for continued treatment upon within 30 days of expiration of the AOT order. So next, just sharing some information in terms of the department's preparatory work for AOT. So here in this slide, we have a map that essentially outlines a data analysis that the department performed in fiscal year 24 to start to gauge potential year one capacity for AOT. This analysis was based on claims data from Optum, at that time our ASO for Medicaid claims. It was specifically an analysis looking at claims for individuals with serious and persistent mental illness who had claims indicating 2 or more hospitalizations within the 3-year period prior to the analysis. That is one of the statute requirements for AOT. And then those numbers were then multiplied by a penetrance rate drawn from the research literature in terms of the penetrance of AOT that has been documented in the population of individuals with serious and persistent mental illness. So we share this as an example of how we are preparing and gauging capacity for AOT. In terms of our implementation strategy, so as of January 2025, all jurisdictions did notify the department that they did not intend to implement AOT. And so we are now pursuing a strategy that includes a state MDH-led implementation of AOT, as well as a phased-in process implementing AOT in 3 priority regions to start. And our goal with this process is to allow a streamlined implementation to maximize success and ensure we can have a process of lessons learned as we roll out AOT statewide. So walking through what we see as the 3 phases in terms of implementation. So this beginning phase, which we are in the midst of this year, is identifying our 3 priority regions, which we have identified. Those will be Anne Arundel region, consisting of Anne Arundel County, Baltimore City region consisting of Baltimore City, and an Eastern Shore region that consists of 9 counties in the Eastern and Mid Shore. We are also working to prepare our infrastructure for that first implementation, including finalization of our COMAR regulations and collaboration with the Circuit Court Judiciary as they develop rules for the AOT process. Phase 2, we foresee consisting of standing up these programs and bringing them to operational status in these priority regions, monitoring those operations, workforce capacity, capturing lessons learned, and engaging our jurisdictions and other stakeholder forums and advisory groups for feedback as we roll out in these 3 regions. Finally, phase 3 will be to expand AOT into all remaining regions, ensuring standardized operations across counties with ongoing engagement from a variety of stakeholder groups that we have convened and been operating during this pre-implementation phase for feedback on the program. Next, I'll be sharing information about our MDH work plan. We have a fairly detailed internal work plan developed in the fall of 2024, separated into different buckets, essentially, or sections in terms of the work around establishing AOT. On the right of the slide, you'll see the list of all the different components that are in this work plan. The 2 that I'll be diving a bit deeper into with this presentation are our stakeholder engagement efforts, as well as our efforts around regulations. So in terms of stakeholder engagement, first, in terms of our engagement with our local behavioral health authorities, core services agencies, and local health departments. So BHA did, in the fall of 2024, convene several stakeholder engagement meetings, which were really geared towards sharing draft operational guidance with our jurisdictional leadership, obtaining their feedback, and working towards providing information to inform that decision whether to implement or not at that jurisdictional level. And once all jurisdictions had declined to implement AOT, we then worked in partnership with our jurisdictional leadership, in partnership with our General Assembly, including we were grateful, of course, for the partnership of Chairwoman Bagnall, as well as Speaker Pena-Melnick, in convening a centralized AOT work group, which has been focused on sharing implementation updates with our partners, reviewing draft operational and clinical guidance, and obtaining feedback on that guidance as well. In response to feedback from the members of that work group, we have also included representation from our jurisdictions in our other MDH AOT advisory groups, which I'll be describing in a moment. Additionally, more recently, we have convened a separate work group that includes leadership at the jurisdictional level from our priority 1 regions to really focus with that group on reviewing operational guidance, assessing how we can best tailor that guidance to the local jurisdictional environment in those priority regions. And lastly, we do disseminate a monthly joint communication developed in partnership with MABA and MACHO to all jurisdictional leadership across Maryland to keep them apprised of our AOT implementation efforts. In terms of our engagement with clinicians, so in the fall of 2024, we convened a clinical advisory group that consists of psychiatrist leadership from several of the major hospital systems in Maryland. And the goal of that group has really been to obtain that group's feedback and expert guidance on our clinically focused guidance materials and processes and procedures. We've additionally, over the summer, held 3 listening sessions for assertive community treatment, or ACT teams. These are intensive active community-based teams who are named in the AOT statute as a potential member of the AOT Care program and who we foresee being a significant component of AOT services based on the eligibility for ACT teams and the eligibility for AOT. And we are now working with the leadership of our Priority 1 jurisdictions to identify additional opportunities to connect with clinical audiences and share information on AOT implementation. In terms of consumers and consumer advocacy organizations, we convened a consumer advocacy advisory group in spring of 2025. This group meets monthly and is comprised of consumers and family members with lived experience, as well as representatives from consumer advocacy organizations, including NAMI Maryland, On Our Own of Maryland, Mental Health Association of Maryland, and the Black Mental Health Alliance. And the goal of this group is really to offer a platform for these stakeholders to share that critical consumer-driven perspective as we're developing our clinical and operational guidance and ensuring that we are appropriately incorporating that lens as we put the components of this program together. In terms of partnership with our judiciary, so we've been very grateful for the partnership and collaboration of Judge Marina Sabet, the behavioral health liaison for the Maryland Judiciary, as well as Judge Fred Hecker, the chair of the Conference of Circuit Court Judges, with whom we've collaborated to convene a judiciary advisory panel consisting of circuit court judges from across the state. And the main focus of this group has been developing a guide of recommended practices for the judiciary for AOT proceedings. In addition to this group, MDH has also been in regular communication with the Judiciary Rules Committee and has attended 2 meetings of the Rules Committee that included AOT rule development as part of the agenda of those meetings. In terms of partnership with the Office of the Public Defender, so we appreciated the collaboration of OPD in their joining one meeting of our centralized work group to provide their feedback and perspective on AOT. And we have also convened monthly joint update meetings with OPD since October 2025, in which MDH shares updates on our implementation and obtains their feedback and perspective as well. In terms of additional engagement, we have provided AOT implementation updates at 2 convenings of the joint meeting of the Commission on Behavioral Health Care Treatment and Access and the Behavioral Health Advisory Council in January and November of this year. Again, we noted that we attended these meetings of the Rules Committee most recently on January 9th and have shared information on those public meetings with our stakeholder groups that they may attend as well. Additionally, to really be expansive in terms of obtaining perspective on AOT and sharing that information with our stakeholders, we've convened monthly AOT court viewing sessions of outside states court hearings to allow our stakeholder groups to have a perspective in terms of how an AOT court hearing may proceed in another state, obtain lessons learned to inform our partners in the judiciary as they're looking towards developing those recommended practices and processes. And we've also facilitated opportunities for collaboration between our advisory groups in response to really helpful feedback from those advisory groups, including some recent combined meetings of our clinical and consumer advocacy advisory groups and facilitating an opportunity for sharing of perspective on judiciary practices with our judiciary advisory group. In terms of regulations, so MDH developed draft regulations, which we posted in October of 2025, and subsequently held 3 video conference stakeholder listening sessions in November and December for a review of those draft regulations and to obtain stakeholder feedback. After the first 2 of those 3 listening sessions, we did post several FAQs responding to some of the questions and comments that came up in the first 2 sessions to help best inform those attending the 3rd session. Since we also accepted written comments from stakeholders through December 31st, and so we have collected those comments and they are under review, and we will be using those to inform revisions to the regulations as indicated. And so one significant revision that we already plan to make, this is that update from earlier in our presentation, though we had previously proposed and included in our regulations a review process preceding the petition in which the state would offer an opportunity for potential petitioners petitioners to submit information for referral and review. We received feedback from multiple stakeholders raising concerns about that process and where it potentially exceeded our statutory authority. And so we appreciated that feedback. We have removed that from our regulations. We have also removed the department as a named potential petitioner from our regulations, although we do anticipate that there will be circumstances where the department will meet the qualification for petitioner as outlined in statute and potentially serve as petitioner. We're also developing a final FAQ in response to our third session, and we've included here our email address for our regulations team for any questions around our regulations process. And so with all of that, we at MDH are committed to developing a robust evidence-based program with a broad array of stakeholders at the table to provide their feedback as we develop this program. Thank you for your time, and we are happy to answer your questions.
Thank you so much. I said you were doing yeoman's work. It is 2:30 now. I want to open it up to questions with the intent of maybe starting our next briefing around 2:45. So with that, I saw Delegate Martinez first.
Thank you, Madam Chair, and thank you all for the very thorough presentation. My question is fairly simple. I wanted to know what went into the selection of the 3 priority regions, and why was Prince George's County not prioritized?
Well, thank you for the question. And what we really aim to balance in making this selection with, I'll say, no sort of underestimating the priority and need in other counties across the state, is our focus was really around geographic variability, ensuring that we're including both central regions as well as outlying counties, where we expected to see high volume in terms of AOT referrals based on our data analysis, as well as jurisdictional readiness based on our collaboration with the jurisdictional leadership. That being said, we are firmly committed upon implementation of those priority 1 regions to immediately look towards lessons learned and move swiftly to implement across the state. And so we certainly recognize the potential benefit and priority, I think, of all other counties as well.
And based off your own charts, it looks like Prince George's and Montgomery, which is on our Washington suburbs, had some of the higher numbers outside of Baltimore City. So when you went to the selection, was it that we didn't have adequate services or leadership ready for this in the county, or is it that you all just had better relationships elsewhere? I'm just trying to understand how the decision was made. If even under your own charts, you see much higher numbers from those areas, but yet they're not in the priority for phase 1.
Absolutely. And I think where that comes in is both balancing that volume also with that geographic variability. And so noting that we do expect the highest volume in the Baltimore City region, but also wanting to look towards not only piloting in these centralized higher population areas, that we want to be sure that in the initial pilot, we're also looking towards how AOT will be operational in areas that are geographically different, including our outlying counties such as the Eastern Shore.
Delegate Kaufman.
Yes. I'm a little bit surprised that all of the counties declined, according to your own slides, if I read it correctly, to provide AOT. Did they give you any rationale? Were there some overall themes? Why did they all decline to provide it?
Well, thank you for the question. And I think the first piece that I would highlight is that this was optional for our jurisdictions. And so they are, of course, within their statutory requirement to either opt in or opt out. And so we do appreciate that they fulfilled that requirement in terms of whether they had a preference to opt in or opt out. I think broadly speaking, of course, I think each jurisdiction has their own differing perspective and understanding of their jurisdictional needs. And so I do want to be careful to speak for individual jurisdictions as far as that thought process. I can say that, and I think particularly in certain publicly available information in terms of county perspective, there was potentially a desire for more finalized items such as finalized regulations, finalized judiciary rules, things of that nature before committing to the program.
No, I just wanted to briefly say amen to Delegate Martinez's questions about why the Washington region wasn't included, but thank you.
Delegate Alston.
Thank you. And piggybacking on the same vein as my colleagues, I am deeply disappointed to hear that no county actually opted in. I'd like to know what the process was that you all used to advertise, and to whom in the counties did you provide information that this was available? And then as a follow-up to that, can you tell me what your plan is for the funding that we've put in place? Because in these budgetary times with things getting tight, I believe your funding is on the chopping block from the budget briefing that I heard, because no counties opted in.
Absolutely. Well, thank you for both questions. So in terms of those who were, to whom we provided the information in terms of the option to implement, so statutes specify that it would be the local behavioral health authority or core service agency who would be overseeing implementation should a jurisdiction elect to implement. And so it was to that leadership that we shared information in the fall to inform their decision-making. And so that was those monthly stakeholder meetings that we convened in the fall from October of 2024 to January of 2025 to provide information, including a process for notifying us of a decision around implementation. In terms of funding, I may ask our Deputy Secretary to potentially add additional information there.
Sure. Good afternoon, and thank you for the question. So regarding the funding, the department, given that we have the responsibility now of implementing this statewide, is investing those resources to bring on staff to support this work, as well as we just released an RFA that has been posted for partnership with community-based providers to help support these efforts. So the department is fully intended to move forward full steam ahead to have AOT operational in the state of Maryland.
Yes, I would strongly like to encourage you all to look at the Washington region and to see if you can combine the Anne Arundel, Montgomery, and Prince George's County region into a region, because that is a huge need for the state. And I know many of us worked very hard to get this bill passed after 20 years of it failing. And to hear that this is what's going to be happening now, I'm sure you all, I may speak for everybody, this is very disappointing for this committee to hear this. And I would like to see it implemented statewide, or at a minimum to hit the areas with the highest prevalence and need. Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. I was looking forward to this presentation today. I was on the AOT workforce, and if any of you were around, I was a dog on a bone about how this was going to be funded at the rural counties. I represent 4 rural counties on the Eastern Shore, and I was assured that this would be funded through the department, and this would not be burdened on my counties. I was just at my Eastern Shore delegation meeting last week, and MACO came and said that we have a new unfunded mandate now being pushed down to the counties called AOT, so it caught me by surprise. So is that correct, that this is now being pushed down to the counties on the Eastern Shore to fund AOT? And if so, can somebody, not now, but get back to me as to what are we looking at in terms of this unfunded mandate, if that's what the case is? I'm very disappointed if that is the case, because I worked hard to make sure that it wasn't an unfunded mandate to the counties.
Thank you, Delegate, for the question. And so in the BRFA language that was released last week, there is a cost-sharing component that was introduced that would come into effect for the counties that operationalize AOT at a 25% increment starting in fiscal year 28. The department is currently exploring that BRFA language, and not dissimilar to any other program that we develop within the Behavioral Health Administration. There's financial modeling that is being done, and that has been done in partnership with the counties to understand what the potential costs would be, whether it be at the state or the county level. So we are happy to provide you with the BRFA language that was introduced. And as I said, we are currently assessing what that potential impact would look like for future out years.
Thanks.
Delegate Hutchinson, we are also exploring that language and looking at what that would do. Yes, indeed. Delegate Johnson.
Thank you, Madam Chair, and thank you for the presentation today. I'm piggybacking off of Delegate Martinez's comment, only because I see the priority regions were set up, but some of the, it says it was based on expected AOT referral volume and geographical balance. And we also have right now the Rural Health Transformation Program. in the state. But yet I look and I see our entire half of our western Maryland has no priority region, and it's a long way to come to Anne Arundel County, which butts up to another priority region, Baltimore City. So on Delegate Martinez's comment, I see that Montgomery and Prince George's County have double the projected demand of Anne Arundel County, and it would be closer to the western half of the state, which to me would seem more geographically balanced. So was any of that considered, and are we going to look into that to make sure we don't exclude the western half of our state?
Well, definitely appreciate that question. And I think certainly our intention in doing this phased-in approach is to not exclude any part of the state, that we will ultimately be rolling this out statewide, and that this was a decision where we were aiming to balance a variety of factors and thinking about urban versus suburban component, central versus outlying as well. We do appreciate the point that there are counties who really are eager for this program and eager to be prioritized to have it implemented. And I would say again that following the implementation in our priority 1 regions, our intention is to expeditiously look to roll out in other regions across the state.
And that would be not to forget the western part of our state.
We will absolutely not
Rural
forget the
areas. All
western,
right.
absolutely, yeah.
Thank you, thank you.
Before I take the next question, I just want to give you an opportunity to further explain and clarify the phased-in approach, the prioritization, and also what that timeline looks like, because I think maybe there's not an understanding that these are all priority. It's more a matter of scale. So if you could just sort of enlighten us a little bit, and then we'll take more questions.
Of course. So I would say in terms of timing, we are working to make these first priority regions operational in the summer of 2025 on that July timeline. And sorry, 26, I apologize. We are in 2026, in 2026. And then looking to roll out across the remainder of these jurisdictions over the course of fiscal year 27. And so I would emphasize this is not a phase-in over multiple years, that we really aim to be expeditious as soon as we have stood this program up in those first regions, to immediately pivot and look towards, as we are learning lessons from those regions, rolling this program out further. I think pieces I would add in terms of the rationale for this, and we were really grateful for the partnership, both of members from the General Assembly as well as our local authorities, was also looking towards feedback that we were receiving from our jurisdictional leadership in terms of the wisdom of looking towards a phase-in for a program of this scale and complexity, involving collaboration across multiple sectors, the judiciary, the department, hospital systems, legal representatives as well, to ensure that we really build the best program possible. And the resounding feedback that we're receiving is that a phase-in, looking to start in a smaller number of regions to begin with, learn lessons in terms of how the program is put together, and then apply those lessons to ensure a robust, strong program across the state was the best pathway.
And just to clarify, that you have full buy-in from all of the local counties, all of the local health authorities and behavioral health authorities with this approach?
This phase-in, yes. This is a decision made in partnership with our jurisdictional leadership.
Thank you. That is helpful. Delegate Hill.
Thank you, Madam Chair, and thank you for the presentation and the work, and that question was actually very helpful. So what I think you're saying is that as we pass the legislation with some budget, if I want to make sure we understand you correctly, local jurisdiction said, we don't know how to do what you're asking us to do, so we're going to opt out. The state said, since you're opting out, we'll go ahead and do it. And the buy-in you're saying is they said, great, we'll be happy to work with you to see this program comes to our jurisdiction over the next year and a half, but you take the lead because this is a lot. Is that kind of what you're saying?
I would say that does capture it. And I think a piece I would add is that we really appreciated that this pivot to a fully state-led approach has not meant that there is no collaboration with our local authorities, that we've been really appreciative of whether it's through that centralized work group, whether it's through their participation in our advisory groups, whether it's through the participation in that additional Priority 1 work group, that they've really come to the table and collaborated with us in terms of offering their feedback on this process. And that, yes, this phase-in specifically was a decision being thoughtful of their perspective and with their agreement and partnership.
Continue, all right, thank you. So, given that there were some funds allotted, that there was a sense that this would not be an unfunded mandate, and that's what our understanding, and now they're being told there's at least a 25% pay-in once it comes to your jurisdiction. And I've heard that that may increase so that over a period of 3 years, they're going to be totally responsible. How can we encourage them to continue with this program if we're so quickly telling them that they're going to have to be responsible for it? Because the benefits of the program that we all anticipate as we pass the bill are not seen on a financial sense that rapidly. It takes a while to see that, in addition to, from a patient standpoint, there's less trauma, they're able to stay out, to see that there are fewer people jailed, there are fewer people hospitalized, that there are some real savings on the local level. I'm not, it almost feels like we misled them saying we're going to do it as a state program, we're going to carry the cost, and then just as we're getting it to your area, you're going to have to pick it up. So can you help me understand? Maybe that's for the secretary. I don't quite understand this funding piece and changing in the middle of the implementation.
No, I certainly appreciate the question, Delegate Hill. And as I said, we are still unpacking what the BRFA language says when we read it last week. And so we are happy to take the question for the record and get back to you.
Say that when we thought that at least some jurisdictions would pick this up, and we now have to do this phase-in, that our initial costs are actually lower than they would have been when we first budgeted it. So there's some savings in this fiscal year over what we had projected for this program, because it's not happening statewide. It's not happening in 12 jurisdictions. It's not happening except in 3 places. So there are some savings already in there over what was originally anticipated and budgeted.
I think what we'd like to do is, again, take the question for the record. I hear you, right? And these are part of the financial modeling exercises that we've been trying to do over the past year and a half with the information that we have. We did see some economies of scale with it being a state-led model, right, for centralizing resources versus having them dispersed into individual jurisdictions for them to have specific carrying costs. So from that perspective, we did calculate some back-end savings for the state rather than having 24 individual programs, right, where we can group specific regions, lift up capacity through other infrastructure investments that we would have across those regions. So, I think this is something that we are going to be delving into further over the next several weeks.
If there's a mandate that's needed in legislation, you're going to let us know.
Yes, ma'am.
All right. May I just ask a final question, slightly different, or we're done?
All right, I will just point out it is 2:46.
As we pull these things in, as you begin to roll this out, is there any role or any nexus with the behavioral health, the mental health courts that are currently functioning in Baltimore County, Prince George's County, Hartford County, and Frederick County? I know those are people who are under arrest, but they're still getting supervised behavioral health treatment, court supervised treatments. Is there a nexus there that you see as we begin to roll those out?
So definitely appreciate the question. I would say that one limitation in terms of that nexus is that statute does specify that AOT has to run through the circuit court. And we know that many of these problem-solving courts, as they're sometimes termed, mental health courts as well as drug courts, are at the district level. And so in terms of where the cases would run, there is that separation. But I can certainly say that we've been gleaning lessons learned in terms of the operations of those courts and where there is that focus on using that sort of court situation as an environment for engagement into treatment. And we certainly noted in viewing our outside state courts, the viewings that we've attended, that we've certainly seen similarities in terms of how a problem-solving court might function in terms of the structure and processes. And so I think we certainly foresee that there could be that nexus in terms of lessons learned.
Please let us know if we need to make some adjustments in that aspect so that we can help you to have the most robust and effective AOT program possible.
And I will also say, Delegate, that there is a statewide steering committee now on behavioral health and in judiciary settings. And I think they are also taking up these questions. So we have multiple eyes on this issue because, once again, AOT is one tool in the toolbox, but we have to make sure that we have a robust system of care. Delegate Riley.
Thank you, Madam Speaker. Yeah, my question, I know that we have a briefing coming up after you with the CCBHCs and who actually do an amazing job within our counties. I was wondering, because I don't know, are they accessed to actually work with this program to where they actually treat folks in the AOT and are reimbursed, or they cannot be accessed for their services? Because they do a great job.
Of course. Thank you for the question. So I think where there could be potential is that as part of the OT program, the individual is court committed to this outpatient treatment plan that has these specific required components, but then is supposed to consist of all outpatient services that are deemed necessary for the health and safety of the individual. And so I think certainly depending on the individual, if there was a circumstance where a CCBHC was deemed appropriate in terms of that service and was the identified recommended provider in that plan, there could be that sort of nexus or overlap between CCBHC and AOT.
To follow up, so are the courts then, are they aware and have a complete knowledge of what our CCBHCs do in the community to say, hey, we're going to say, send you there? Because, I have a sheet of paper here, and shows you the, thousands of people that they actually help in several different categories, in every category. So it seems like they would be a great resource, and those would be available in those counties that we don't have, anyone. So I don't know. So are the courts aware of what our local behavioral health clinics do?
So I definitely appreciate the question. I guess I would first make one distinction that in terms of, while the court ultimately orders the AOT plan and puts in terms of what is court ordered into place, the plan development is done by this care coordination team. And so I think but to your point, I think we'd certainly be thinking about the awareness of that team as well as our judiciary of these forms of services. And so I would say we take that as, I think, important feedback in terms of awareness amongst our judiciary colleagues in terms of community behavioral health services.
Help the data showing that we're helping more people under this program, I think, if we would use that resource. So thank you very much. Appreciate it.
Thank you.
And our last bite at the apple is Delegate Taveras.
Thank you, Madam Chair. And I'll be super quick. I just want to say thank you for the phenomenal work that you're doing. I had an incident in what was technically Delegate Martinez's district. I had a call from one of the churches, a member there, and she was going through some things with a child of hers, and this had just been implemented. I sent her to court. We downloaded the paperwork easily on the judiciary database, and the pastor helped, Padre Vidal, helped her fill it out. They took it straight to the courthouse that same day, wrapped it up, got a hearing, and she was able to get the assistance that she needed. This was obviously all in Spanish, and it was something we could give it some follow-up on this issue to see how well the process works with this case. But I just have to say thank you because it made my job so much easier.
Thank you very much, Delegate Taveras. I just want to say thank you again for all the work that you've done and for coming and explaining to us and clarifying. To our members, I also want to say that appropriations is going through their very deliberative process and their work. I'm sure that they would welcome your feedback on this particular issue because they are aware, and in our Health and Human Services subcommittee is also looking at the budget and its potential impacts. Thank you so much for being here today. This concludes our 1 o'clock briefing. We'll be going down for a moment to start our 2 o'clock briefing, probably at 3.